Welcome to Bioethics in the Margins. We are a group of bioethicists from different institutions across the country. This podcast represents our views and those of our guests, but we do not speak for our universities or medical centers or for bioethics organizations. Our mission is to bring marginalized topics and voices into the bioethics discourse. This podcast is hosted by Dr. Amelia Barwise, Associate Professor of Medicine and Biomedical Ethics at the Mayo Clinic, and Dr. Kirk Johnson, Assistant Professor of Justice Studies and Medical Humanities at Montclair State University. Please enjoy this conversation.
Welcome to another episode of Bioethics in the Margins. We're very excited to have Dr. Kadija Ferryman here today. And Dr. Ferryman is an anthropologist who studies equity and policy and health risk prediction technologies. She is faculty at the Berman Institute of Bioethics and an assistant professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Before her training as an anthropologist, Dr. Ferryman began her professional career as a policy researcher at the Urban Institute in Washington, D.C. She's published many articles in journals such as JAMA, the New England Journal of Medicine, one which we're going to discuss today, and the American Journal of Bioethics, as well as the Journal of the American Informatics Association. Dr. Ferryman received her BA in anthropology from Yale University and her PhD in anthropology from the New School for Social Research. So you're very welcome, Dr. Ferryman, and thank you for being here.
Thank you so much for having me.
So you're a cultural anthropologist focusing on health information technologies. And so for our listeners, can you tell us a bit about what that means? What does a cultural anthropologist do in this space?
Yes, so first I will give a brief overview of cultural anthropology and what that is. So cultural anthropologists look at behaviors, beliefs, attitudes, and values that people hold and how these behaviors, beliefs, attitudes, and values are expressions of how people understand the world, how they understand their community, and understand society. And so cultural anthropologists ask questions like how people define what things are. So, how do people in different cultural groups understand what a family is? How do they understand, what marriage is supposed to look like, for example, right? So, part of what we do is try to understand the way that people define things. We also try to understand how people understand hierarchies in their society, how they understand the importance of hierarchies, how they function, and how power is distributed in societies. And as cultural anthropologists, we also try to look at where within groups, within cultures, societies, there are often contradictions. So, how sometimes those behaviors, attitudes, beliefs and values may contradict each other. And so most people, I think, when they think of anthropologists, they think of someone in, some location that's not in the global north, let's say, and, understanding, spending a long time trying to understand a social group, let's say, maybe a small social group. And that is some part of what anthropologists do. But myself, as an anthropologist who studies technology, I study a lot of the same things that other anthropologists study who study, let's say, outside of their own native culture. So also looking at beliefs, behaviors, attitudes, and values, and how in groups where technology is being used, how people in those groups are understanding what technology is, what it means, how it functions, how those technologies have an impact on social hierarchies, power, distribution of power, and how their values, again, sort of shape some of those fundamental understandings. So that is cultural anthropology overall, and then an anthropologist of technology, which is a way that you can think about what I do.
Fantastic. So I suppose now with AI, there's going to be plenty of things for you to study. So what drew you to this field? How did you get into this?
Yeah, so I will mention how I was first drawn to anthropology generally, and then how I became interested in studying technology as an anthropologist. So my first exposure to anthropology was in college as a college student, as a first year college student. And I attended an anthropology class. I believe it was Intro to Cultural Anthropology. And I was really shocked and compelled by a presenter, our professor, who explained that diseases are different in different places. So things that kind of sets of characteristics that we in America may not consider to be an illness in other places, those characteristics might be considered to be an illness and vice versa. And that was really the first time that I could even conceptualize something like that there are cultural differences in terms of something like understanding what a disease actually is. And so from that point, I was hooked. I was hooked on anthropology. And part of it is because I have a sort of bicultural upbringing. My parents are immigrants, and I grew up in the US. And so I had spent a lot of my time growing up really navigating some of the cultural understandings that my parents and family had about things and some of the American cultural understandings. And so when I took this anthropology class, it was this way for me to understand what I had been trying to sort of puzzle over and think about really, as a child growing up. So that is how I first got to anthropology. And then how I got drawn to anthropology of technology, and specifically the way technology is used in health and medicine, and some of the cultural and ethical dimensions of that is a little bit sort of further in the future. And that really starts with I had become really fascinated by the debate between social scientists and life scientists when the human genome was sequenced. And some of the listeners may remember there was this pretty fierce debate, articles in the New York Times, things like that, commentaries going back and forth, and essentially social scientists on the one hand saying that the sequencing of the human genome shows what we've been stating for decades, which is that race is a social construct, and the life scientists and geneticists and things saying that, and I'm generalizing here, but trying to get to the kind of basic crux of the argument, the life scientists and social scientists saying, hey, sequencing the human genome now gives us an opportunity to probe and prove scientifically that there are these differences in humans by racial groups. So we can look at the less than 1% difference that we see between, in humans to try to identify where race lives in the genome. And so I was really struck by this debate and really struck by how this group of academics, researchers who both really felt like this discovery, one, meant very different things to them. And I believe we're both motivated by good intentions, right? Both wanted to use the scientific resources at hand to do, in some senses, what I do: learn more about what makes us human and what is how do we understand what it is to be a human. Both were really trying to ascertain that, but interpreting this finding, this discovery, this sequencing of the human genome in very different ways. And so that's how my focus on ethics and the sort of social side of technology, that's where that really crystallized for me.
Awesome. Okay. So it seems like your interest started with the genomics, but then you've done a lot of other work since then. You've been involved in exploring bias and racism in many different areas. And we didn't really kind of introduce this idea of bias yet, but you've been looking at bias and pulse oximetry, which became quite widely known during the COVID-19 pandemic. So maybe you can touch on that. But you've also been looking at bias and racism in clinical prediction algorithms, the genomics that you sort of introduced, precision medicine. So maybe just touch on that, and then we can kind of move on to the generative AI and how that's changed some of your work.
So, as you stated, pulse oximeters are devices which measure the level of oxygen saturation in the blood, but these devices don't measure blood directly. They measure the oxygen saturation through the skin, so sort of estimate what one's blood oxygen saturation is by essentially how light reflects through your skin. So these devices have been in use in medicine for decades. And it's also been known for decades that these devices don't work as well the more melanin someone has in their skin. So again, because the device uses reflections of light from the skin, it's been known that people with more darker pigmentation, more melanin in the skin, that these devices don't work as well. And these devices not working as well actually means two things. One, it means that often pulse oximeters give more varied readings in people with darker skin, people with melanin, with more melanin. And then the other way that pulse oximeters don't work as well in people with dark skin is that pulse oximeters tend to overestimate oxygen saturation in people with dark skin. So they tend to report that someone's blood is more oxygenated than it actually is. And so in the medical context, that can be very dangerous because as you can imagine, we need oxygen in our blood. And if there's a device telling you or a clinician that there's more oxygen, your blood is more oxygenated than it really is, that can be problematic. And pulse oximeters were invented as an alternative to more invasive methods of measuring blood oxygenation. So you can actually measure how oxygenated someone's blood is by taking their blood, right? And actually measuring it. But those procedures, they're arterial punctures, they can be painful, they take longer. And so pulse oximeters are this way to avoid that and get this measurement in a quicker, easier way for both clinicians and patients. And I should note that pulse oximeters are used in hospitals. So there are sort of hospital grade pulse oximeters that are medical devices. And then there are the pulse oximeters that are available at drugstores that are not considered medical devices by the Food and Drug Administration's definition. They're considered recreational kind of health and wellness devices because they can be purchased and used by consumers. And in the COVID-19 pandemic, because knowing part of sort of understanding or staging people's illness, blood oxygenation level was a key metric. And the use of the over-the-counter pulse oximeters became sort of more relevant and as it relates to COVID-19. So there are reports of people, going to emergency rooms and being told by their clinicians because of wait times, et cetera, to use a pulse oximeter and to manage, to use the pulse oximeter to monitor their blood, their oxygen level, and that if it got below a certain percentage, that would be the way for them to come back to the hospital, right? So these devices became very important, or these tools, I should say, became very important in that COVID-19 context. And so even though the bias in pulse oximeters, the bias against dark skin has been known for decades, the problems with those problems with pulse oximeters sort of reemerged in the public eye because of their increasing use during the COVID-19 pandemic. And so myself and my colleagues from Johns Hopkins, we did a research study where one of the questions that we wanted to answer was, we really wanted to find out why this problem, this bias problem essentially of pulse oximeters, if it's been known for decades, why was it still a problem, right? Like what was done on the federal side to try to address this, and why are pulse oximeters still problematic, still biased in the way they are today? So one of the things that we did was we looked into data, publicly available data from pulse oximeter manufacturers. So when a medical device maker wants to get approval from the FDA to market their device, they apply to the FDA to get approval. And there was in 2013 guidance issued from the FDA stating that there should be, because again, these problems were known even before 2013, that pulse oximeter manufacturers should strive to use more diversely pigmented subjects in their testing that they do of their pulse oximeter devices. And so what we did was we used the publicly available data to see how well pulse oximeter manufacturers actually adhered to that recommendation from the FDA. And what we found was that after this recommendation, only a quarter of pulse oximeter manufacturers even mentioned using more diverse subject populations, skin tones, et cetera, in their applications to the agency. So what that meant was, now that was a higher percentage than before the FDA recommended that they use more diverse skin tones, more diverse subjects in their performance testing. But nonetheless, what that meant was that about 75% of pulse oximeter manufacturers didn't include any information about testing pulse oximeters across a diverse range of skin tones. And part of the issue there is that this was a recommendation from the FDA. It wasn't a requirement. And so what we found was that most actually just didn't follow the recommendation. And so that's not the whole answer, but that's part of why we are here today, where there are pulse oximeters that are have this bias against dark skin, but are still being used clinically and still being sold over the counter to consumers. So that is part of the story on bias in pulse oximetry.
Oh, well, fascinating. And what's interesting is not just in this particular field. As you know, Dr. Ferryman, in kidney misdiagnoses and dermatology, the misdiagnosis of skin cancer, and pulmonology with individuals with asthma. Unfortunately, this issue of misdiagnosis using these different technologies are really impacting people of color, whatever hue or skin color you are, skin tone you are, across many specialties of medicine. So thank you very much for emphasizing this issue that really needs to be addressed, because if it isn't, then it's going to continue to perpetuate health inequities in every particular specialty and field. And sometimes when we have these conversations, I feel like I'm on a hamster wheel, because I'm running, we're keeping on talking about it, but we're really not seeing any at least relevant or legitimate responses to rectifying the issues that you are discussing in our podcast today. And with that particular concern, of course, now we have a new technology. And as you know, technology in itself isn't bad or good. It's how we use the technology that presents, ethical issues or actual altruism in itself. And of course, the elephant in the room now is generative AI, right? And do you believe that the same problems that we are, currently talking about and that you mentioned will be the same problems in this new setting, in this new technology? Or is there something fundamentally different about generative AI that can possibly rectify the ills and the harms of past technologies?
Yeah, that's a great question. Yeah, thank you for that and bringing Gen AI into the conversation. So Gen AI suffers from and will suffer from many of the same issues that we've seen with previous technologies, like machine learning that's used in healthcare, like the pulse oximeters, for example. Gen AI will be subject to many of the same problems with the same root causes. So, for example, with pulse oximeters, with some of the biases that we've seen in non generative AI, or let's say machine learning tools in AI, one source of bias is the lack of diversity in the training data, right? So with the pulse oximeters, there's the lack of diversity in terms of performance testing of the device. We see that also in machine learning tools for health, a lack of diversity in terms of the training data that's used to build the tool. So Gen AI will be subject to that similar kind of issue, that similar source of bias, that depending on what the tool is trained on, if there's a lack of diversity, you'll see some of the similar biases in the outputs or in the way that the tool functions. There also may be maybe similar issues in terms of bias that we've seen in other AI tools, specifically where the tool is designed to predict something, but it's actually predicting, because of the data that it's used, it's actually not predicting what it sort of thinks that it's predicting. This kind of proxy problem, and so we may see versions of that with generative AI. But there are some important differences with generative AI, and one is that because of the interface. So the interface that generative AI has is very different from the way that and if we're just situating this in terms of healthcare, that interface, that Gen AI interface, is very different than the interface that the clinician sees with a machine learning predictive algorithm. So a clinician might interface with a machine learning algorithm in their electronic health record, and it will look like a score or a prediction that says this patient is predicted to have X disease or X risk of this disease, or if it's analyzing an image, a prediction of where there could be a pathology in the image. Gen AI, as we know, has this kind of more human chatbot, let's say, kind of interface, this conversational interface. So it doesn't look like a score or a report or a risk score or something like that. And so that kind of interface is distinct from other kinds of machine learning AI, and could present different kinds of biases. So we know that in non-generative AI, research has been done showing that clinicians can kind of rely, in some instances, can rely more on an AI's output and expertise, sometimes even going against their own clinical expertise. And there is a risk that Gen AI, especially because it is in this chatbot interface, or even more of this, if it's even more than a chatbot, let's say it's an avatar or something like that, that format may exacerbate some of the issues that we've seen with machine learning AI, where clinicians are trusting the AI more than their own clinical expertise and clinical judgment. There's also a unique vulnerability with generative AI, again, specifically when it's used in healthcare, although this issue is part of Gen AI when it's used in other contexts, and that is the ability for Gen AI to memorize its training data, and when prompted, and if prompted enough by a skilled enough prompter, it can be prompted to reveal its training data. And so you can imagine, if this is a Gen AI tool that's used for healthcare and it's been trained on very sensitive data, that is a privacy vulnerability, right? That we don't see with machine learning tools, where you can't prompt a machine learning AI to learn to have it tell you about its training data. If anything, with machine learning tools, it's sometimes the opposite problem, that those are black boxes, and clinicians don't know what the AI is basing its predictions on and what it's weighting in order to make its decision or recommendation. But with Gen AI, there's this problem of, you can prompt it to get it to actually tell you what it's been trained on, and if those things are confidential data or information, right, that can be a real privacy risk. And then, of course, all of these things are exacerbated in situations of inequity. So privacy risks are problematic for everyone, but we can imagine that those risks might be even more dangerous, let's say, for a minoritized group, a marginalized group, where the tool can reveal its sources of information and its sources of learning. So I guess my answer is yes and no. So yes, there are some Gen AI is subject to some of the same source problems and issues as non-Gen AI, but because of the interface, and particularly this vulnerability of it being able to kind of reveal some of its training data, make it a bit different than some of the forms of AI we've seen thus far.
Oh, yeah, absolutely. And before we dive into Dr. Ferryman's amazing article, was really a great read in the New England Journal of Medicine, entitled "Considering Biased Data as Informative Artifacts in AI-Assisted Healthcare." This was published August of 2023. So our listeners there, or who have access, I highly encourage you to read it. Our conversation also brings me back during COVID-19 when we were all quarantined, and there was this I don't know if it's still on Netflix, but there was a really great documentary by a Black sister named Joy Buolamwini, and the actual title of the documentary is called Coded Bias. Really great, informative documentary about many of the things that Dr. Ferryman is speaking. And so if anyone's interested, it's called Coded Bias. If it's not on Netflix, I do apologize, but because this was about 6 years ago when I watched it on Netflix, but the title is Coded Bias. And for those who are interested, other than, of course, reading Dr. Ferryman's article in the New England Journal of Medicine, if you're a visual learner like myself, this is also a good opportunity to dive in and learn a little bit more about this issue. But back to the article, and I know in your recent, this particular article, you and your co-authors reframe this terminology, garbage in, as a cultural artifact. Can you explain what garbage in, what that means?
Yes, and thank you so much for that question. So this paper really came out of discussions that I had with my one of my computer science colleagues, Marcia Gassimi at MIT, and Maxine McIntosh over in the UK, Genomics England, and we have been interested in this issue of bias in machine learning and technology for a long time. And so when this idea of bias started really gaining traction, we were like, oh, this is a good thing, right? But as we continue to kind of observe and participate in these conversations around bias and how AI tools can be biased, we started noticing a disturbing trend and it can be summed up by this computer science adage, garbage in, garbage out. So meaning that if you're building a tool and you put garbage in, what you're going to get out is going to be garbage. So your tool is going to be garbage too. And in some senses, that is what myself and others like Joy Buolamwini were trying to identify in identifying sources of bias in technology, right? To say that if you have a tool that's trained on not a representative, not a diverse data set, that tool is then not going to work well for everyone's, right? So that aligns with that idea of garbage in, garbage out. But our issue with that, like I said, even though we were proponents and participants in that conversation, was that we were saying, well, that doesn't, instead of saying, okay, if there's a tool, it's been trained on biased data, that tool itself is in some cases harmful, but we were reticent or feeling cautious about the idea of saying, well, let's throw that tool out, and that tool is meaningless and doesn't tell us anything important in action. And so, in fact, what we wanted to say was that those tools, trained on biased data, actually can tell us some really interesting things about the data, about how the data was collected, that is actually not garbage, that can be really informative information about healthcare today, right? So essentially, it's sort of turning around, because what we saw people who were identifying this idea of bias, saying, okay, well, if I want to build an AI tool and there's a biased data set or a non-representative data set, that data set is garbage. And so I just have to get a different data set, or I need to somehow augment that data set. Maybe I fill in, do mathematical ways of filling in the missing populations, or maybe I add synthetic data to that. Maybe I try to enrich that data set in various ways. And our message in that article was, wait, hold on. Let's not throw out that biased data set before and immediately either throw it out or try to fix it. Let's analyze it and look at it for what it's trying to tell us about the healthcare system. So for example, if you have a data set that's biased in the sense that, let's say, women of color are not well represented. Yes, that's a biased data set. And if you build a tool on that, your tool is going to be likely biased against women of color. But what we're advocating in this paper is to say, well, let's take this as an opportunity to say, well, this data set, why is it that women of color are not well represented in this data set? Is it something about how if it's a data set of procedures, is it something about access to that procedure? Maybe women of color are not getting referred in equitable ways to get that procedure. Maybe there are other sorts of biases at the institutional level. Maybe there's not access, geographic access in terms of that particular procedure, why women of color may not be getting access to that tool. And so therefore they are not well represented in that data set. So we were really trying to say, let's look at what those so-called biased data sets tell us about some of the inequities we see in the healthcare system and the larger and society at large. So that's where we got this idea of like, hey, these data sets and even the tools that don't work well if they are built from biased data sets, they really are artifacts in the sense that, me as an anthropologist, when one of the things that anthropologists do, for example, is when they're trying to, if they're looking at an ancient society, let's say, right, you look at the artifacts, you look at and even in current societies, right, you talk to people and try to understand how they understand the world, but you also look at the things they use and their tools, their artifacts, things like that, right? And you try to understand their world through the material things that they use. And so we wanted to frame data sets in the same way that we would, if we were, again, an anthropologist, that we would analyze, let's say, a drinking vessel from an ancient society and say, well, what does the color, the shape of this drinking vessel tell us about this particular society? We wanted to do the same thing with those biased data sets to say, well, if we look at this data set, what does it actually tell us about, again, healthcare, access, inequities, society at large? So that is the argument that we were really trying to make. And it was, we were very passionate and still are very passionate about this topic, but we were a little cautious because we wanted to make sure that our message was coming across clearly and that we weren't trying to say that bias is not important or bias is good or something like that, right? We weren't trying to say that that you should ignore bias or it's okay or it's good to have biased data sets and biased tools, but that there are ways to really interrogate these biased data sets and tools. And also, too, it wasn't because Marzia is one of the premier computer scientists in the country, if not the world. And so she herself implements some of the strategies that we talk about in the paper, like imputing missing data or developing synthetic data. We also weren't demonizing those as saying that technical folks shouldn't try to enrich data sets, let's say, but our argument was that shouldn't be the only strategy if there's a biased data set, right? We can also do this step of trying to understand in a broader sense what the data is telling us.
Oh, yeah, no, absolutely. So what's interesting is you mentioned artifacts, and obviously these codes have to come from somewhere. And obviously these codes come from people. And I'm interested if in your research and your understanding of people, because that of course is an integral part of anthropology, has there been any work in the foundational aspects of these algorithms? Because the algorithms come from the code and the code comes from the actual person. Have there been like cultural competency or any type of work, to your knowledge, that works from the foundations of this issue? And then from the foundations, we could actually start building towards some type of, reconciliation, some type of restitution that I want to say prevent bias, because, bias sometimes is inevitable, but at least try to deter or hinder bias in some particular way, shape, or form. So that is my, follow-up question, because I'm thinking artifacts, well, artifacts is really from, this the etiology, it's the origin of a problem. And not to say, every person that codes is racist, because that is not, I would never say that. However, there is a bias that is led at the foundation of these different mechanisms that it seems, at least in my opinion, hasn't been addressed properly. So I'll digress. I know that was a long question/comment, but this is based off of your answer from the previous question.
Yes, so there, and that's a great question and comment. There's been fortunately increasing attention in technical fields like computer science and engineering around incorporating ethics and social implications of technology really even into curriculum at the even at the undergraduate level. So before I was at Johns Hopkins, I was at NYU, and I was recruited there to help them update their engineering curriculum, the ethics portion of their engineering curriculum, because previously it had focused on kind of moral philosophy that had some relevance to current technology, but not in the sense of kind of broader social impacts and the technologies that are being used today. So NYU, a number of other training programs in computer science and engineering in the less than a decade or so, there has been really increased attention and a recognition of we really need to build in more attention to ethics and social implications of technology into our curricula. And it's funny, my cousin, who's an aerospace engineer, I remember when I was designing or kind of redesigning the NYU ethics and technology curriculum, I asked him, can you tell me a little bit about what your ethics training was like, so that I can kind of get a sense and see, and as I'm developing this technology, as I'm developing my curriculum. And he was like, I didn't get any ethics training in my, engineering work. So that is a big, important change that is happening at the level of education institutions. And at Hopkins, for example, we are really investing in not just AI technical training, but responsible AI, trustworthy AI, again, offering courses on ethics of AI technology as part of that technical training. And I think to answer your question about foundations, right? The foundations that's often the training. And so having that be a part of education, like I said, computer science, engineering, technical education at the undergrad and graduate level is really important, and where you can begin to make sure that considerations of those kinds of issues are really foundational to technical skill development. So that's one change that I'm seeing that's been great. Another is just that, again, even in the technical communities, there's been an increasing attention to ethics and how that is important to not only their methods, but how their work will be useful or not to, because at the end of the day, computer scientists, engineers especially, are trying to build tools that solve problems. And so if their tools are biased and are riddled with some of these issues, that's going to go against their own interest of making tools that are useful and helpful. And so there are conferences on fairness, accountability, and transparency, for example, that have really emerged from within technical communities themselves to try to wrestle with some of these issues around fairness and bias within those tools and methodologies and things like that. So that has also been a really encouraging development.
Great. So it sounds like you're somewhat optimistic about there's been some response to this sort of bias within AI, which is great to hear. Are there any other steps that you think that sort of healthcare institutions can take when they recognize bias, and if they need to protect marginalized populations for which algorithms aren't working when we're deploying AI in clinical care? Any other steps that we should have?
Yes. So again, another encouraging trend is, like I said, there is increased attention to bias and how they can show up in healthcare algorithms. And so there are a number of frameworks that address bias and health equity concerns. So, for example, there's the Health Equity and AI Across the Life Cycle framework, which really is a framework that is designed to help people at healthcare institutions, AI model developers, to really keep health equity at the forefront throughout the development of the AI tool. So from its development, thinking about what kind of data you're going to use, to model testing, because there's often sort of trade-offs in how you have to, adjust your model. And if you keep health equity as part of that, that can help inform the decisions you make around even fine tuning or calibrating your model to then implementing your model and then evaluating your model. So there are a number of, that's just one, but there are a number of responsible, equity focused AI frameworks that are available and really helpful tools. There's also organizations like the Coalition for Health AI that have equity as a core value of theirs, and also they provide frameworks and metrics and ways for healthcare institutions that are implementing AI, using AI guidelines for how to, again, incorporate considerations around equity, incorporate considerations of equity in their model, even procurement, let's say procurement, deployment, and evaluation. I was also part of a National Academy's effort to develop an AI code of conduct for healthcare. So for AI that's used in healthcare and research, and equity is a key part of that AI code of conduct. And so that AI code of conduct is sort of like a framework of frameworks, if you will. It's sort of like a meta framework that pulls in learnings from the multiple other frameworks that deal with responsible, trustworthy, equitable AI. And so equity is a key part of that model, or a key part of that framework, which is great as well. And the other good thing about the National Academy's Responsible AI Code of Conduct is that we had that code of conduct was developed in partnership with representatives from healthcare institutions as well as representatives from industry. So the hope is that this is a code that will be useful for healthcare institutions as well as industry, where many of these healthcare AI models are developed and sold and marketed as well. So those are some steps, or I guess there's a lot of tools and resources out there for healthcare institutions that really want to center equity, make sure that they're considering marginalized communities and marginalized groups. There are a number of resources out there, which is great.
Now, the NIH has recently cut, obviously, its research on bias, which is concerning. Do you think, your approach, which is really novel to kind of consider these artifacts, is sort of one approach to use to move forward in the field? Or any other ideas about how we can kind of continue to monitor bias, since AI is growing exponentially and we can't stop it? So we need to also sort of keep an eye on where this is moving in the current climate.
Yes, thank you for that question. And it also reminds me that, sorry, and maybe this could be appended to the other question, because I just remember two other things to add in terms of what healthcare institutions can do. So evaluation and audits. Evaluating the AI tool is really, really important. So a healthcare institution can evaluate an AI tool. Let's say if it's from a third-party developer, they can ask for information about the tool, model cards, for example, that include information about the model, how it was developed, what data was used. And that's really important on the outset, on the kind of getting the AI tool. If it was validated in a similar population as the population that it's going to be used in. So there's a number of steps that healthcare institutions can do at the outset, which is great. But then once an AI tool has been implemented or used in a healthcare institution, it's really important to also continue to evaluate and audit that tool to see if the tool is continuing to work in the way that it's expected, if it is having different impacts on some groups of patients versus others. So there's also steps that can be taken once the tool itself has been used and is being used in the healthcare organization. And this is where we're also seeing a rise in AI governance structures and committees at healthcare institutions. So this is something that Paige Nong, who is a researcher at the University of Minnesota, has done some research on, trying to map this increase or this rise in AI governance at healthcare institutions, because healthcare institutions have realized that the process doesn't just stop when they purchase, let's say, an AI tool or develop their own AI tool and begin to use it in their system, that there's really this ongoing process, including of evaluating and monitoring and auditing the system to see how well it works. So institutional AI governance is really important. The other thing I want to add too is that in this conversation, we've been focusing mostly on clinical healthcare AI tools. So AI tools that are used to predict, disease or some kind of condition, but it's also really important to look at non-clinical AI tools. So tools that are used in healthcare organizations, but not necessarily for a clinical function. These could be tools that are used to optimize scheduling, to optimize uses of operating theaters, for example. And there's some early research showing that tools, for example, AI tools that are used to optimize patient scheduling, that those may also be having different and inequitable impacts on marginalized groups, right? So that there are certain groups for whom, they might be predicted to be more no-shows, et cetera. But that kind of prediction may not speak to the individual and their individual shortcomings, but maybe again there are some structural barriers that individual is dealing with, and those what seem on the face to be sort of administrative tools can be again exacerbating some of the larger patterns of inequity that we see in the healthcare system. It's also really important too for healthcare institutions and others to pay attention to how AI is being used clinically for clinical functions, for administrative functions, but also for in health insurance, right? So there's a whole other side of healthcare, which are health insurers, who are also using AI in their processes. So, for example, to process claims, for example, and maybe issue denials. And so in Maryland, we actually have passed legislation just last year requiring that healthcare insurance companies report to our insurance commissioner if they've used AI tools in claim denials. So they have to actually report that to our insurance administration, and the insurance administration reviews those reports to see, how AI is being used to impact, again, what kind of healthcare coverage people are getting. So that's another, important dimension of sort of where in healthcare AI is being used. It's really being used in a number of domains. To your other question in terms of how to move forward, especially in this funding environment, I mean, this is a really tough funding environment for healthcare research overall, very, very tough. But I do think that there are some paths that we can take. So, for example, the NIH is the largest funder of biomedical research in the US, if not in the globe, I believe, across the globe. It was a large, and Johns Hopkins is the largest recipient of federal research dollars in the US. And so this funding environment has really had, honestly, negative impacts on our ability to do the really important life-saving research that my colleagues do at Johns Hopkins. And so what we're seeing is that our faculty, research, clinicians, scholars are looking for alternative sources of funding, outside of the federal government, looking to philanthropy, but even, philanthropy now, because there are so many people shifting over to philanthropy, right? That is kind of a limited resource, but that is one strategy that people are doing, kind of looking to philanthropy for funding. There also is something to be said for how we frame the message. So part of this funding environment is there's been a real rejection of research that focuses on diversity, equity, and inclusion, right? And a lot of our conversation has been around how important diversity actually is in medical devices, right? Like pulse oximeters don't work as well because of subject pools that don't include a diverse enough range of skin tones. So like in very concrete ways for medical research and for medical devices that we all use, like diversity is actually really critically important. And I think it's important to identify the specific ways, especially in healthcare and medical research, where diversity is really critical, where attention to diversity really is critical, and that research on marginalized groups, let's say again in this conversation we've been talking a lot about marginalized groups and how do we focus on equity and make sure that marginalized groups are not, some of the challenges that marginalized groups face in this country in healthcare are not being exacerbated by AI tools. But the other part of that message and of that focus on marginalized groups is that when you do research and design interventions to address some of the challenges that marginalized groups are facing, that research often ends up benefiting everyone and not just the marginalized group, right? So, for example, the classic case that I think about is sidewalk ramps, right? Sidewalk ramps were originally designed to help people with wheelchairs. But in fact, now those ramps actually help all of, so many other kinds of groups, people with limited mobility who are not in wheelchairs, people with strollers, younger children, right? So focusing on a particular marginalized group does not mean that that research, those interventions that you want to do will only positively affect that group. It's not a zero sum game in that way. And so I think there's a real opportunity today to reframe or really emphasize that part of research of diversity, equity, and inclusion research on marginalized groups, research on health disparities, that yes, we are focusing on groups who are facing disadvantage, but that research and the way that it's done often improves and has benefits for a wider swath of the population.
Oh yeah, absolutely. And you said it so diplomatically rather than I say it in other conversations. So thank you for thank you for the nice balanced tone in this real big issue that diversity is something that is an asset. It's actually something that benefits everyone. It's not detrimental. It's not a liability in the many different levels of research and also in the clinic as well as medicine overall. So thank you for that. So, switching gears to precision medicine, this is actually an area that I'm really excited about, and that artificial intelligence actually can help in many different ways to help alleviate a lot of the illnesses and things that are plaguing a lot of people, especially rare diseases. Can you talk a little bit about how genomics may contribute to racialization and how the concept of bounded justice may help scholars explore ethical, legal, and social implications, as we know as LESI, of genetic and genomic research?
Yes, thank you so much for that question. So, yes, there is precision medicine holds a lot of promise and actually has already had a number of successes around using tailored information about individuals to tailor their healthcare. So, precision medicine can be summed up as the right treatment for the right patient at the right time, and that is the goal, which is a fantastic goal of precision medicine. But there is, a danger in or a vulnerability in precision medicine where the the focus in some aspects of precision medicine, a sort of focus on genetics and especially genetic ancestry groups, right? So in precision medicine, there's been some attention looking at how uh, genetic variants that may be connected to a disease, how those are differentially distributed in different populations, right? And there can be a danger to make a leap from saying something like in precision medicine, we have found that this genetic variant that increases the risk of kidney disease, we found this gene this genetic variant, it's found more often in people of African descent than people of European descent, specifically people of West and Central African descent versus people of European descent. There's a danger that that jump or there can be a jump in interpretation to mean that that genetic variant is more common in Black people versus white people because genetic ancestry and social racial groups, even though there are some overlap, they're not completely the same thing, right? So there is a genetic variant that is connected to increased risk of kidney disease that is found more often in people of West African, Southern African ancestry more than people of European ancestry, but it's actually not found at all in or a very low frequency in people of East African ancestry. And so we know that, at least in the United States, the racial category of Black includes everyone pretty much of African descent, right? People from West Africa, people from East Africa. And so if you collapse this idea or collapse this notion of a genetic variant that's found more often in West African populations into the social category of Black, you could have, let's say, a clinician seeing someone of East African descent in their, in their practice and say, oh, I read that there's a gene that's more common in people of, African descent. So I should, test this person. This person may have that gene, but if they are of East African descent, there's a very low chance that they might actually have that gene, right? So we have to be very careful about collapsing ancestry, genetic ancestry, and social race, because as I said, those two groups are related, but they're not completely overlapping. So that's one caution around precision medicine and using genomics and genomic ancestry to inform healthcare that I think it's important to again just be mindful of. Again, the National Academies recently produced an important report encouraging researchers to be very specific when doing genomics research, to be very specific and thoughtful about how they are naming their population groups. If they're actually using a population group, if they're using a genetic ancestry group, if they're using a social racial group, and the reasons why, making sure that they are clear and provide justifications for the population categories or labels that they use in their research. So that I think has also been really important and helpful for researchers as they guide, which can be, this tricky terrain, right? We as humans, we often make these mental shortcuts. We make these heuristics. So you could think about it, it makes sense that if someone hears, oh, there's a genetic variant, it's more common in people of Western and Central African ancestry, that if you see someone in who would be socially recognized as Black, that you would think, okay, this is something that's relevant for them. But as I said, because there's not that complete overlap, and actually that gene is pretty much absent in many Eastern African countries, that wouldn't be the right the right kind of next step, or that wouldn't be the right interpretation, let's say the right interpretation to have. So there's that. And then this idea of bounded justice, which comes from the brilliant scholar, science and technology scholar, Melissa Creary at the University of Michigan, who developed this concept of bounded justice to describe where health equity researchers, public health researchers who have good intentions to design, let's say, an intervention to address a documented health disparity, how that good intention and even a well-designed intervention study may really only be addressing a part of the reasons why there's that health disparity in the first place, right? And so as a result, she uses this term bounded justice to describe there could be justice in offering or designing an intervention that's meant to increase access to healthcare, or let's say increase access to a particular test for a particular marginalized group, but that justice that you would get from that intervention, there would be some level of justice there, but it would be sort of bounded because it wouldn't address all of the kind of structural issues that are really contributing to those disparities that we see. It's almost like if you've seen online, there's sometimes pictures of, a big wall with a big crack in the foundation, and someone puts a Band-Aid over it, right? That in some ways, that's a way to kind of think about part of what Creary is trying to discuss in Bounded Justice. And again, Creary is not to demonize or criticize public health researchers, disparities researchers, which she would call herself as being a part of that group, but really to more draw attention to these larger structural inequities that are connected to some of the disparities in treatment, in access, treatment, and outcomes that we see in healthcare. And so, if we put that in the context of precision medicine, it is really important to think of bounded justice with precision medicine. So again, if precision medicine is the right intervention or the right treatment for the right patient at the right time, but in the context of bounded justice, if you are able to, let's say, develop a genomics-based treatment that's able to, let's say, target someone's cancer, right, on a genomic level, that could be great. But if that individual, because of structural factors, isn't able to, let's say, take time off of work to get that treatment, yes, you could have precision medicine, you could have that precision medicine discovery, but it may not be available in an equitable way, or that having that kind of precision medicine intervention could be an example or could be a case of a kind of bounded justice, right? That it's available in on one level, but is it available and is it really addressing some of these larger structural issues? So that's the connection there between precision medicine and bounded justice.
Thank you so much, Dr. Ferryman. Really enriching conversation, and I definitely agree. People from African descent, from the African diaspora, definitely not a monolith, right? But there's many diversities and many different intricacies and cultures and ethnicities and languages and so much other diversity within that group that we definitely need to always consider when we're looking at diagnostic tools in its many forms. So we could talk on and on, but I know that you have to go. So we definitely appreciate your time and your expertise in this area.
Thank you so much for having me. This has been a really great, thought-provoking conversation.
Thank you for listening to another great conversation on bioethics in the margins. This podcast is hosted by Amelia Barwise and Kirk Johnson. Our producer is Elizabeth Chung. Our editor is Madeline Mahoney. Our theme music was written and produced by Pablo Cortes. And we are grateful for the assistance of Veda Koda and Benjamin Foster. Join us again next time.